Dr. Scott Sellinger, and I'm a urologist in Tallahassee, Florida, specializing in advanced prostate cancer. And we're very happy today to have an esteemed panel with us, and we're going to go through some new ideas and ways that we can help take care of these challenging patients with advanced prostate cancer. Gentlemen, I'm going to let you introduce yourselves. Casey?
Hey, my name is Kethandapatti Balaji. I'm an actively practicing urological oncologist in Florida. I am a urological surgeon. In addition, I take care of patients with advanced urological cancer with special interest in prostate cancer.
Okay. And Rob?
Rob Zaiden, medical oncologist in Jacksonville, Florida at Baptist MD Anderson. I treat a wide range of urologic malignancies as well as some gastrointestinal malignancies. I do have a particular interest in prostate cancer as well.
And Chris?
I'm Chris Murphy. I'm a urologist at Ascension St. Vincent's healthcare system in Jacksonville. I have a background in robotic oncology and specialize in prostate cancer and kidney cancer as well as general urology.
Well, for sure this whole prostate cancer space is just blown up. And I remember the days 30 and 40 years ago when I started out in urology, we didn't have a lot of options. We've got some unbelievably good options now for our patients. But how important is it to identify these patients and adequately categorize them? You know, which bucket or which quadrant do they fall in? You know, we ask, are they metastatic, are they non-metastatic, are they castrate-sensitive, are they castrate-resistant? And when we put that all together, we typically have a drop down of treatment options. You know, Rob, you're shaking your head. How important is that to adequately categorize those patients?
Thank you, Scott. I think it's very important. I would add that you also would categorize as high volume, low volume disease. As you said, we've had an explosion of different therapies, more importantly, the doublet and triplet therapies. So for us as medical oncologists, risk assessment is usually at the forefront of treatment decisions.
Right, you know, and we look at that journey that patients go through, and most of our patients, Chris, we can cure them with local therapy, and even a lot of them don't even get treatment, right?
Correct. You know, the majority of prostate cancer is localized and low risk, although we're going to be talking more about a different set of prostate cancer, more advanced today. But if we catch it early enough, it is a very manageable disease.
So Casey, one of the buckets that we're seeing a lot of is this metastatic castrate-sensitive space. And we know back around 2012, the United States Preventive Services Task Force said it's a D rating to do PSA screening. How do you think and now and we've picked up to a C rating in 2018, but it's still not really where we want to be. How do you think that that's affected this just influx of patients that are showing up with metastatic castrate-sensitive disease?
You're right. So, you know, we are seeing an increase in the number of patients with metastatic disease, and there's also an increase in the incidence of prostate cancer. If we've seen about 5 or 10 years ago, the annual rate was about 250,000. Now we are going over 300,000. Now, you know, the challenge is the temporal. You know, we think of prostate cancer as a slow-growing disease, so you wouldn't expect this rise to be directly related to it. But that's certainly a contributing factor, and there's probably other factors involved as well. But what is clear is number of patients with advanced prostate cancer, metastatic prostate cancer is increasing.
And Rob, so when we talk about transitioning from the early stages into those middle groups and then finally to the far end of the spectrum with metastatic castrate-resistant disease, we know that the therapies now that we have in the metastatic castrate-sensitive space oftentimes can prevent transition into metastatic castrate-resistant disease. You're a medical oncologist. You know what these patients face with castrate-resistant disease. I mean, what are those patients dealing with when they transition into that final stage?
So it's for a lot of these patients, it's been a long journey. All of us here probably remember the days where single modality ADT was the preferred treatment. In the community, there's still 1 in 5 patients that are in single modality ADT, and I think as physicians, we always worry about extra toxicity. In metastatic disease, we know for the most part we're not going to cure these patients, and so quality of life and longevity play a big role in all of our treatment decisions. I think for us as medical oncologists, having a very honest discussion with our patients about expectations, about the realities of their disease, and about the treatment options is usually the starting point.
And then when we look at monitoring for progression of disease, because that's really what this is all about, when you transition from a castrate-sensitive space to a resistant space, it's typically some progression. I mean, Chris, you know, we have modalities now that we can use to look at progression. Do you look at PSA? Do you look at radiographic changes? Do you look at symptomatic changes? What do you think are the important issues for you when you're looking at assessing those progressive?
Yeah, I think you incorporate all three of those things. Obviously, I think it starts with a rising PSA and confirming that and checking to ensure castrate levels of testosterone. And then depending on the PSA value, I think you're going to, at this point in time, I think primarily we're in the generation of PSMA PET imaging primarily. At least I can say that's pretty much what we're getting most of the time in that scenario.
Well, I'm glad you brought that up because PSMA has totally revolutionized what we've done. So was it fair to say now that CT and bone scan are dead? Are they dead? Or are we still seeing some of that utilized?
Well, you know, in certain population there may be a role. I mean, it's more to do with affordability and availability. So, and in some patients, say comes in with a PSA of over 1,000, you know, they're very likely to have positive conventional imaging, CT and bone scan. There may be a role, but I agree with Chris. I think we are in a era of PSMA PET scans, and that's probably is our first line.
Do we ever see any more this question of low volume on one scan and high volume on another scan, and then we sort of in this dilemma of, well, how do we really categorize that patient?
I think this is a very interesting question, Scott, actually a loaded question. We know from Charted and Stampede that the high volume and low volume disease was on conventional imaging traditionally. That's kind of what all these algorithms have focused on. PSMA scans were approved, I believe, in December 2020, and most of us have never looked back. But we know that it has higher sensitivity and higher specificity than conventional imaging. And so for most patients in my practice, that's really where I start.